today's meeting. I welcome Dr. Sharda Jain, Chief Expert. We start today's session. It is on first semester miscarriage and ectopic, the recent guidelines. The first lecture is by Dr. Renu Chawla. It's on the advantages of dydrogesterone in progesterone deficiency and miscarriages, the recent guidelines. The chairperson, we have first Dr. Dipti Nabh ma'am. She's the Director, Mother and Child Center. She's a Senior Visiting Consultant at Max Hospital. She is presently the Vice President of Delhi Gynae Forum East, the past Secretary of our forum. And she's area of expertise is infertility, high-risk pregnancy, menopause, and she has received various awards. And we have Dr. Poonam Goyal ma'am. She is the HOD IVF, Max Hospital, Director and HOD of Obs and Gynae at Panchshir Hospital. She has authored and edited various books, Conception to Delivery, Endometriosis, Fibroids. She is also a receiver of many various awards, Corona Warrior Award, the Wonder Foxian Award, and many more. Then we have Dr. Shama Batra. She is the former Secretary of Indian Medical Association East Delhi branch, former Finance Secretary of IMA EDB, and she is Executive Member of EDGF and DMA. She is also a member of various other organizations like Foxy AOGD. Welcome. Then we have Dr. Neerja Varshney, ma'am. She is the present consultant at Cloud9 Hospital, Bimla Devi Hospital, Mayur Vihar, Garg Hospital, and Lifeline and Geo Hospital, Delhi. She has been in charge of the maternal and child at Aruna Hasapali Hospital, the past consultant at Lal Bahadur Shastri Hospital, and ex-HOD Obs and Gynae at Hedgewar Hospital. She has special interest in endoscopy, urogynae, fetal medicine, adolescent health. Welcome, ma'am. And the first lecture will be taken by Dr. Renu Chawla. She is alumni of Lady Harding Medical College and Sucheta Kriplani Hospital. She is the present joint secretary of our forum, and she has a keen interest in high-risk obstetrics. Welcome, ma'am. I request Dr.
Dr. Renu, share kariye.
Dr. Renu, ma'am, please.
Dr. Renu, you are muted. Unmute yourself.
Dydrogesterone is a great salt, and we find this particular salt has been there in the market for last 60 years, and gynecologists have been using it left and right. Especially the Indian doctors have been using it for a very, very long time. So you all know the usage of it in threatened abortion. You all know its usage in recurrent miscarriage. You all know its usage in luteal phase defect, and you also know its usage in endometriosis. So I think Dr. Renu Chawla is just going to highlight this particular aspect in a more detail to you. So all of you know it. This particular salt, you've been using it for the last 60 years. The only thing is what you have to suit it. Every company wants their product should be promoted.
Good afternoon, everyone. Topic for today is dydrogesterone advantages in progesterone deficiency and miscarriage, recent guidelines. As we all know, there are multiple risk factors for high-risk pregnancy like maternal age, obesity, as well as higher BMI, history of miscarriage, pre-existing medical conditions, pregnancy complications, and lifestyle. We have 4 most common risk profiles of pregnant women, like if her early pregnancy loss is higher among women aged 35 years and above, if she has PCOS, which accounts for 20 to 50% of early pregnancy loss. Being overweight increases the risk of miscarriage by 29%, whereas if the woman is obese, this risk increases to 71%. Women with a TSH between 4.5 to 10 had an increased risk of miscarriage of 1.8 times compared to women who had a normal TSH. Identifying women at risk of threatened miscarriage. Prognostic factors for identifying high-risk pregnancies, that is by history, sonographic evaluation, and maternal serum markers. Adverse prognosis is seen if the woman's age is more than 34 years. Previous miscarriages, especially in older women, increase the risk in future pregnancies. Favorable prognosis is seen if the woman presents with the advancing gestational age at first consultation. So advanced maternal age and increasing number of previous miscarriages deteriorates prognosis. Sonographic evaluation, with this we can come to know about the favorable prognosis if fetal heart activity is present at presentation. Then it is 97% likelihood of successful pregnancy. Adverse prognosis is seen if there is fetal bradycardia, there is discrepancy between gestational age and crown to rump length, or empty gestational sac with a diameter of more than 15 to 17 mm is seen. So all these factors, they cause an increased risk of miscarriage to the tune of 90%. Maternal serum markers such as serum beta HCG, if values are low, they indicate higher risk for miscarriage. Serum progesterone and progesterone-induced blocking factors, they are promising prognostic biomarkers for threatened miscarriage. Spot serum progesterone measurement at presentation can triage women with threatened miscarriage and guide subsequent management. Serum progesterone levels of more than 35 nanomoles per liter make it a low risk group. And if PIBF concentrations which are detectable and quantifiable in serum and urine of pregnant women, if this parameter is used, usually PIBF levels, they increase continually till 37th gestational week and then they decrease. So miscarriage rate is high when PIBF is absent at 3 to 5 weeks of seemingly normal pregnancies. Progesterone deficiency can be modified using suitable progestrogens. Progesterone induces secretory changes in the lining of the uterus essential for successful implantation of a fertilized egg. Progesterone deficiency, that means inadequate secretion of progesterone during the luteal phase, is linked to etiology of miscarriage. Progestogen supplementation beginning in the first trimester of pregnancy is used for the treatment of threatened miscarriage to prevent spontaneous miscarriage. Progestational effects of dydrogesterone, they are demonstrated on endometrium, vagina, cervix. It helps in residua formation and maintenance of pregnancy. Dydrogesterone's effects, as they are demonstrated on these sites, we can see from this figure that there is a configuration difference between dydrogesterone and progesterone, which makes it favorable. Formulation and route of administration. Progesterone can be given in injectable form, it can be used vaginally, or it can be used orally. Injectable progesterone can be given intramuscularly, or subcutaneous injections can be used. Injections cause sufficient secretory transformation of the endometrium. But the adverse effects are injection site pain and skin irritation, which may result in inflammatory reactions and abscess formation in some cases. Vaginal progesterone, although is well tolerated by most of the patients, and it also causes adequate endometrial secretory transformation, but transvaginal route can cause discharge and vaginal irritation in some of the patients. So it may be unacceptable to some patients. Oral progesterone is the easiest route of administration and generally the most acceptable route for the patient. Patients prefer oral administration over injectable and vaginal routes. Oral dydrogesterone is approved in threatened and recurrent miscarriage treatment, also in treatment of infertility due to luteal insufficiency and other progesterone deficiencies. There are almost 600 published articles globally to support this evidence, and it is also available in almost more than 100 countries. Oral micronized progesterone, despite micronization, the systemic bioavailability of oral micronized progesterone is still relatively poor. Because of poor bioavailability, higher dose is required to maintain pregnancy. So high dose, if we are using, it increases the risk of intrahepatic cholestasis and is associated with drowsiness to marked sleepiness. Oral dydrogesterone, not only it is effective in its pure form, also its metabolites like DHT, it shifts cytokine balance towards Th2 cytokine production that is conducive to the success of pregnancy. Plus, DHT induces nitric oxide synthesis, which improves the endometrial receptivity and pregnancy outcome. Here we can see that comparison between dydrogesterone and oral micronized progesterone. Dydrogesterone has been approved for use in threatened miscarriage, recurrent pregnancy loss, luteal phase insufficiency, and other progesterone deficiencies, whereas use of micronized progesterone is only in secondary amenorrhea. It has been approved only for secondary amenorrhea. There are more than 600 articles globally available, whereas there are no well-controlled trials for use of micronized progesterone in cases of miscarriage. Dydrogesterone is available in more than 100 countries, whereas micronized progesterone is available only in India. Bioavailability is almost to the tune of 28% for dydrogesterone, whereas oral micronized progesterone is less than 5% bioavailable. Dydrogesterone minimizes unwanted effects and activation of other unwanted receptors, whereas metabolites of micronized progesterone can cause dizziness and drowsiness. DHT, being the metabolite of dydrogesterone, is conducive to successful pregnancy, and nitrous oxide synthesis improves endometrial receptivity and pregnancy, which is not been seen with the micronized progesterone. Oral dydrogesterone is effective in management of threatened miscarriage. There are many randomized trials conducted to prove this. Based on data from recent systematic reviews and meta-analysis, oral dydrogesterone has been found to be effective in pregnancies to continue in women with threatened miscarriage. 40 milligrams stat dose followed by standard dose is the most preferred dydrogesterone regime, as it has resulted in significantly higher continuing pregnancy rates in all the studies. This has been a trial conducted in 2009 where 191 women with bleeding before 16 weeks were taken. The treatment group received 40 milligrams stat dose of dydrogesterone followed by 10 milligram BID until 16 weeks. The control group was given only conservative management with the bed rest. And the results showed that the 40 milligram stat dose of dydrogesterone followed by 10 milligram BID up to 16 weeks of gestation had beneficial effects in maintaining pregnancy. NICE Guidelines for Diagnosis and Initial Management of Miscarriage 2019. This guideline covers diagnosing and managing miscarriage in women with complications such as pain and bleeding in early pregnancy, that is up to 13 completed weeks of pregnancy. It aims to improve how early pregnancy loss is diagnosed and the support women are given to limit the psychological impact of their loss. Throughout a woman's care, provide the woman with, especially with her consent, her partner, to the woman and as well as to her partner, specific evidence-based information in a variety of formats, which includes when and how to seek help if existing symptoms worsen or new symptoms develop, including a 24-hour contact telephone number. What to expect during the time she is waiting for an ultrasound scan. What to expect during her care, including expectant management, such as the potential length and extent of pain and or bleeding, and possible side effects which should be tailor-made. Information about post-abortion care, what to expect during the recovery period, for example, when it is possible to resume sexual activity, when to try to conceive again, and what to do if she becomes pregnant again and get tailor-made care. Information about the likely impact of her treatment on future fertility. Early pregnancy assessment services should be available regionally so that an early pregnancy assessment service is available 24 hours and 7 days a week. It should be a dedicated service provided by healthcare professionals competent to diagnose and care for women with pain and or bleeding in early pregnancy. They should offer ultrasound and assessment of serum human chorionic gonadotropin levels. The services should be staffed by healthcare professionals with training in sensitive communication and breaking bad news. Services should accept self-referrals from women who have had previous miscarriage or a previous ectopic or molar pregnancy. All other women with pain and or bleeding should be assessed by a healthcare professional such as a GP, accident and emergency doctor, midwife or nurse. Ensure that a system is in place to enable women refer to their local early pregnancy assessment service to attend within 24 hours if the clinical situation warrants. If the service is not available and the clinical symptoms warrant further assessment, then the woman should be referred to the nearest accessible facility which offers specialist clinical assessment and ultrasound scanning. Diagnosis of viable intrauterine pregnancy using ultrasound scans offer women who attend a service a transvaginal ultrasound to identify the location of pregnancy and whether there is a fetal pole and heartbeat. If the woman is not ready for transvaginal scan, then she should be informed that by transabdominal scan, we may miss some information which is vital for her for the diagnosis. Consider a transabdominal ultrasound scan for women with an enlarged uterus or other pelvic pathology such as fibroids or an ovarian cyst. Inform women that the diagnosis of miscarriage using one ultrasound scan cannot be guaranteed to be 100% accurate, and there is a small chance that the diagnosis may be incorrect. When performing an ultrasound scan to determine the viability of an intrauterine pregnancy, first look for fetal heartbeat. If there is no visible heartbeat, but there is a visible fetal pole, measure the crown lump length, and if fetal pole is also not visible, then measure the mean gestational sac diameter. If the crown lump length is less than 7 mm with a transvaginal ultrasound scan and there is no visible heartbeat, perform a second scan after a minimum of 7 days from the first ultrasound before making a final diagnosis. If the crown lump length is 7 mm or more with a transvaginal ultrasound scan and there is no visible heartbeat, then seek a second opinion on the viability of the pregnancy and or perform a second scan a minimum of 7 days after the first. If there is no visible heartbeat, when the crown lump length is measured using a transabdominal ultrasound scan, record the size of the crown lump length and perform a second scan a minimum of 14 days after the first before making a diagnosis. Offer medical management to women with a confirmed diagnosis of miscarriage if expectant management is not acceptable to the woman. Explain what expectant management involves and that most women will need no further treatment. Also provide women with oral and written information about further treatment options. Give all women undergoing expectant management of miscarriage oral and written information about what to expect throughout the process. Advise on pain relief and where and when to get help in an emergency. Expectant management. Use expectant management for 7 to 14 days as the first-line management strategy for women with a confirmed diagnosis of miscarriage. Explore management options other than expectant management if the woman is at increased risk of hemorrhage, for example, if she is in her late first trimester, or if she has previous adverse and or traumatic experience associated with pregnancy, for example, stillbirth, miscarriage, or antepartum hemorrhage. If she is at increased risk from the effects of hemorrhage, for example, if she has coagulopathies or is unable to have a blood transfusion or there is evidence of infection. Offer a repeat scan if after the period of expectant management, the bleeding and pain have not started, suggesting that the process of miscarriage has not begun. Or the symptoms of bleeding and pain are persisting and are increasing, suggesting incomplete miscarriage. Discuss all treatment options, continued expectant management, medical management, and surgical management with the woman to allow her to make an informed choice. Review the condition of a woman who opts for continued expectant management of miscarriage at a minimum of 14 days after the first follow-up appointment. If the resolution of bleeding and pain indicate that the miscarriage has completed during 7 to 14 days of expectant management, advise the woman to take a urine pregnancy test after 3 weeks and to return to individualized care if it is positive. Medical management. Do not offer mifepristone as a treatment for missed or incomplete miscarriage. Offer vaginal misoprostol for the medical treatment of missed or incomplete miscarriage. Oral administration is an acceptable alternative if this is the woman's preference. For women with a missed miscarriage, use a single dose of 800 micrograms of misoprostol. Advise the woman that if bleeding has not started 24 hours after treatment, she should contact her healthcare professional to determine ongoing individualized care. For women with an incomplete miscarriage, use a single dose of 600 or 800 micrograms, depending on the choice. Then offer all women receiving medical management of miscarriage, pain relief and antiemetics as needed. Inform women undergoing medical management of miscarriage about what to expect throughout the process, including the length and extent of bleeding and the potential side effects of treatment, including pain, diarrhea, and vomiting. Provide women with a urine pregnancy test to carry out at home 3 weeks after medical management of miscarriage, unless they experience worsening symptoms, in which case advise them to return to the healthcare professional responsible for providing their medical management. Advise women with a positive urine pregnancy test after 3 weeks to return for a review by a healthcare professional to ensure that there is no molar or ectopic pregnancy. Surgical management, where clinically appropriate, offer women undergoing a miscarriage a choice of manual vacuum aspiration under local anesthetic in an outpatient or clinic setting, or surgical management in a theatre under general anesthesia. Provide oral and written information to all women undergoing surgical management of miscarriage about the treatment options available and what to expect during and after the procedure. Thank you.
Very good.
Thank you, Dr. Renu ma'am. We would like the chairpersons for their expert comments.
Thank you, ma'am. Dr. Renu ma'am. It was very nice, and very nicely you have told about regarding the dydrogesterone that we use very regularly. Only one thing I just want to know ki when we should start as early as possible and how frequent, like till what weeks we can give, we can give dydrogesterone.
Once the pregnancy has been documented to be intrauterine, we can start giving progesterone, and it should be continued till 16 weeks of pregnancy.
What about in infertility patients? So many IVF people, they are writing from the starting only.
They are writing, but there is a problem. If ectopic pregnancy is there, it will continue. So we have to see both ways.
Is it necessary to do serum progesterone level for all patients? Yeah, only the threatened abortion, yeah, recurrent pregnancy loss, we have to do serum progesterone.
If it is a high-risk pregnancy, or if it is a IVF pregnancy, it is better to do progesterone levels so that we are guided by if the progesterone levels are low, we should supplement with the dydrogesterone or minus progesterone, whichever is available.
Thank you, ma'am. Thanks a lot, ma'am.
Dr. Poonam,
Anybody else wants to comment? I just want to make, if there nobody else is there, I just want to make a couple of things. I think your presentation, Dr. Renu, had been absolutely superb. And the only thing which I wish is that we all know that after the diagnosis of pregnancy by a urine pregnancy test, even a primary gravida must know that the chances of spontaneous abortion is to the tune of 15 to 17%. Now, if we find a fetal heart activity, so the patient has presented with threatened abortion, if there's a fetal heart activity seen, it shows that the chances of continuation of this particular pregnancy is very good, except ART patients. This particular protection is not offered to the ART patients more than 35 years of age. There it has been seen, even if the fetal heart activity has been there, the chances of discontinuation of pregnancy or it is getting induced abortion are very high, to the tune of also 15 to 16%. So this is, I just wish to tell you that how a person who is a low risk with threatened abortion has a different prognosis, and a person who is a high risk and coming from the ART background, PCOD background, threatened abortion, this background, there the chances of protection is less, even if you find a fetal heart activity. There's another possibility. Another possibility is that you find a clot, subchorionic hemorrhage, and sometimes the clot is as big as the sac, or even bigger than that. Again, the prognosis when you give to these patients that we are doing our best, we are doing everything, but the chances of miscarriage, in spite of everything which is going to happen, it will again fall into 15 to 16%. So, except in a low-risk patients, you find that things are really good. But I think you asked Dr. Shama Batra one thing about it. how soon in a patient of normal pregnancy, if she has a bleeding, when should this salt should be started? This patient should be always told they should keep 4 tablets of dydrogesterone in their purse, even if they're working. So if before they consult to the doctor, may take about 2 hours or 3 hours, they should have had these 4 tablets of dydrogesterone right in the office wherever they're working, or right in the house they are working, and then the husband has to pick her up and then bring it up. Then these 4 hours probably will help her in a continuation of pregnancy is much more. And I think, very beautifully you highlighted the guidelines, which I think each one of us should know it. I think probably we can have a repeat kind of a thing, that one must know the sac size, one must know whether the yolk sac has come, what is the size of the yolk sac, all those kind of small things. I think each and every gynecologist who's practicing obstetrics must know. I can see Dr. Poonam here. I want her to re-emphasize these particular couple of points which we have just highlighted. Over to you, Dr. Poonam.
Thank you, ma'am. One thing the Shama just now was asking about ART patients. In ART patients, because there is luteal phase insufficiency in all the patients, luteal phase is not ready. So we start progesterone right from the day of ovum pickup, or before we even plan for embryo transfer. So progesterone is started from that point. And then previously it was said that just take it to 12 weeks, but now the newer guidelines, they say that we have to take it up to 16 weeks. So that is all. And even if we, after that 16 weeks, if we want to give, then the indication becomes little more different. Then we want the quiescent uterus for that, or sometimes if there is multiple pregnancy, in those patients we can even continue the drug till late, or we may change the drug if we don't want to continue to drolute. Then we can change the drug to progesterone's micronized vaginal use drugs. That can also be changed, or injection of prolutone, that can also be used. Just what madam was saying, that in first trimester scan, we have to be very careful. If it is matching with the dates and cardiac activity is present, then the spontaneous abortion chances, they are definitely decreased to a larger extent. But whenever there is subchorionic hematoma is present, or whenever the sac size is going to be 21 mm and the sac size is 21 mm and there is no embryonic pole, in those particular patients, that is not good. And if the CRL is going to be around 7 mm and still you are not finding the cardiac activity, so those patients, and you are not seeing the good yolk sac in those patients, then you must repeat a scan even after a week or so, if you have any doubt. And still, if you are in doubt and you have not started beta HCG, then you can repeat 48 hours difference of beta HCG. If the beta HCG has increased to the required extent in 48 hours, then also there is always will be a possibility that the cardiac activity will come, and we can do the scan after 10 days.
Thank you, Dr. Poonam, ma'am. We have
Thank
Dr.
you, Seema.
Dipti Nabh.
Dr. Jyoti, anybody wants to comment? Who are the experts?
I do. Dr. Jyoti is, I think, not able to unmute herself.
Dr. Jyoti, you go and join this meeting again. I think that will be the only way.
Log out and join again.
Highlighted. Dr. Poonam, will you like to comment about recurrent miscarriage? What is the role of dydrogesterone?
Ma'am, dydrogesterone has a very good role in recurrent pregnancy loss also, and we start the dydrogesterone right from day one when we do the scan and see that there is an intrauterine pregnancy demonstrated. Maybe the beta HCG levels are still 1500 or 2500, and we see the intrauterine sac from there, and then we can start the drug. And even if our patient is more than 50 kg or 60 kg of weight. Suppose she is 80 kg in weight or 90 kg in weight. In those particular patients, I start 30 milligram per day.
I think, Dr. Poonam has probably told what is the practice of all the gynecologists here. Whether you find the cause or you do not find the cause, empirically, they flood the patient with the estrogens, and the progestogens of choice is dydrogesterone. So this is just to highlight, to complete that threatened abortion you have done, and you use in recurrent miscarriage as well. Even if you find the cause, you do not find the cause. Senior people like Dr. Poonam says that she starts the day the pregnancy test is positive. Any Shama Batra, you want to make any comment on this, or anybody wants to make a comment on this?
I just want to ask one thing, like the recurrent pregnancy loss, already patient or 2 to 3 pregnancy losses are there. If we are planning for the 4th pregnancy, can we start early without seeing the sac?
No, Shama, without
Renu Chawla, you want to make any comment, beta?
There is always a
No, ma'am, it should not be
started. Possibility of pregnancy of unknown location. Even when in good machines, even beta HCG comes out to be 1500, उससे पहले तो patient आता ही नहीं है हमारे पास. तो हमें एक intra तो दिख ही जाता है. Then you are relieved. फिर वो pain तो सारा दिन ही बताते रहते हैं. These patients, they are most of the times, and they are worried, even चाहे गैस का पेन हो, कुछ भी पेन हो, बस पेन है तो they are in panic. These patients, they are in panic. वो आते रहेंगे, पेन है, तो आपको भी डाउट रहता है कि you have started so many things and we don't even know the pregnancy is intrauterine or it's not intrauterine. So it will be wise to do a TVS. You can just demonstrate a small sac around 5 mm, 4 mm, बस हो गया.
Okay, thank you, ma'am. Thanks a lot.
I think, Dr. Renu very beautifully highlighted one of the causes of threatened abortion or miscarriage is lower progesterone level. And we find that this blocked endogenous progesterone may block the journey to your motherhood. And what it does, dydrogesterone as a salt does not block the endogenous progesterone secretion. Yes. And secondly, I think never ever forget the immunomodulatory effect. TH1 cytokinins are pregnancy disaster they bring. But once you use this particular salt, as far as the progesterone is concerned, the intrauterine environment is changed to TH type, and which is pregnancy conducive, and you find that the pregnancy, in spite with all the symptomatic precautions and things like that, the pregnancy continues. That's the advantage, that you should never ever forget the immunomodulating effect of the dydrogesterone as a salt. So I think anybody wants to make any comment? Dr. Jyoti Bhaskar, you wanted to make any comment? Dr. Jyoti Bhaskar? Dr. Ila, you want to make any comment? They are frozen.
Then we can switch.
Network issue.
Yes.
We can start the next presentation.